Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Ambreen and I'm continuing with the subject physical agents and electrotherapy 1. And today I'm going to tell you about electro diagnosis. This is a topic that is from the electrotherapy 1 and from the topic of low frequency current. And we are now moving towards electro diagnosis. Earlier we have studied about all those currents like interrupted direct current, like Faraday current, and sinusoidal diadynamic current, and then mathematical ionization. So now we're moving towards electrodiagnosis. So it is a topic that is going to connect how the electrical currents are going to do diagnosis. We know electrical currents are useful and for therapeutic purposes, like they are going to heal up the tissues, that they are going to decrease the pain. Similarly, they can also be used to in order to diagnose certain conditions. So coming towards today's topic, firstly we will move from the learning objectives. And the learning objectives basically includes the key points of the previous lecture. We have previously gone through the topic of pain. Today we are going to study about electrodiagnosis, and in the next session we will study about the electromyography. So let me tell you what we have studied in our previous lecture. Previously, we have studied about pain. What is pain? Pain is unpleasant sensation that a person is going to experience. And with this complaint, he or she is going to come to the physiotherapist and to the doctor. And we have different physiotherapeutic modalities by which we can reduce the pain. And we have gone through a topic of pain gate 3, that how we can close the pain gates by by stimulating the mechanoreceptors, chemoreceptors, and thermoreceptors. We're going to like stimulate the large diameter traffic, and we can, by this traffic, we can suppress the small diameter traffic. And this is said to be pain gate theory, which was proposed by Malzek and Wolf, that if you are going to stimulate the large diameter traffic, it would get dominating over the small diameter traffic, and this way it will close the gates for the pains for the small diameter traffic. Coming towards the next point we have gone through in the previous lecture is descending pain suppression system. That we can suppress the pain by giving the nociceptor stimulation by the process of counter irritation. We can stimulate the descending pain suppression system in our brain and at the level of the nucleus and periaqueductal area, that is going to send the messages and through descending neurons, and it is going to release enkephalins and endorphins, and these enkephalins and endorphins, they are going to suppress the substance P, and through which the pain is going to be closed. Coming towards today's topic, that is electrodiagnosis. As the term is indicating, it is something electrical diagnosis with the help of electrical current. So what it is a method of obtaining the information about the disease by passively recording an electrical activity of the body parts, and we can also measure the response to external stimulus. So what it includes is, it includes how we can use electrical currents to like measure certain response or by giving an external stimulus. Moving towards like next to what are the goals of electrodiagnosis, why we need to do electrodiagnosis, how it is going to benefit us. Actually, it is going to benefit, or it is the goal of like our goal of doing this is to confirm the site of the lion. We want to know the site of the lion at which level the lion lies. We want to actually estimate the severity of the injury. The next is to judge the pathophysiological nature. What is the pathophysiology of that like lion? And then the lastly, we want to know the prognostication. I mean, what would be the possible prognosis that we are going to expect? If we are going through the electrodiagnosis, we must be able to know, we will be actually able to know either this lion will be giving us good prognosis or either it is going to give us bad prognosis. So let me tell you, whenever there is a disease or an injury of the motor nerves of the or muscles, there are alterations that are liable to occur. Obviously, there will be altered response whenever there is somehow any injury or like any like issue. So the altered electrical reaction may be considered assistance in diagnosing the type and extent of the injury. Actually, by using electrical current, what we can do is we are going to get a response, and that response would be able to help us to diagnose what the type and what the extent of lion it is. So let's suppose if there is a reduction or somehow loss of some involuntary power of a muscle, It may be due to certain reasons and due to certain causes that can be either the the upper motor neuron lions due to which there is a reduced or altered nerve response or power response, and there might be of upper motor neurons that is going to give you reduced or loss of involuntary power of a muscle. It may be a damage to muscle itself directly, a fault of a neuromuscular junction, as we have seen in the case of myasthenia gravis, and somehow due to some functional disorders, due to some psychological issues. Moving towards each point in detail, we are going to discuss what is this lower motor neuron or upper motor neurons, what are lower motor neurons, what are the possible lesions that can be by upper motor neurons, what are the possible lesions that can be the lower motor neurons, what are their signs and symptoms, and how we can assess them by using these electrical currents. Either we can use electrical currents to improve upper motor neuron layers, either we can use on lower motor neuron layers. What's the relationship of the current with the muscle damage itself? What either the electrical currents are going to be any helpful in case of neuromuscular junction, either they are helpful in case of functional disorders. So we are going to discuss what actually they are and what's the sign and symptoms, how we can improve them. So the parts of the motor pathways which are normally accessible for the electrical stimulation are basically the lower motor neurons. Below is exit from the vertebral canal, the muscle itself, but we are actually not able to deal anterior horn cells and upper motor neurons. So anterior horn cells, the upper motor neuron are such category that we can't use electrical current over them. So where we can apply the current is basically our muscle or our nerves that are exiting from the lower motor neuron lanes from the spinal cord and towards the muscle, the peripheral part of the muscle, nerves. So let me tell you about the sets of the neurons. This is from your anatomy and physiology, that what is the upper motor neuron layer and what are the signs and symptoms. I'm going to revise them so that we may move forward. As you know, the central nervous system influences the activity of the skeletal muscles through two sorts of the neurons. One is upper motor neuron and the other one is lower motor neurons. Actually, upper motor neurons are responsible for conveying the impulse for voluntary motor activity through these descending motor pathways. What they do is they are going to convey the impulses for some voluntary motor activity through some descending motor pathways. They send fibers to the lower motor neurons and exert direct or indirect control over the lower motor neuron of the cranial and the spinal nerve. Let me tell you about the tracts that are under the upper motor neurons, how they are going to function. Upper motor neurons controls the lower motor neurons through two different pathways, pyramidal tract and extrapyramidal tract. Pyramidal tracts are like corticospinal tract, extrapyramidal are reticulospinal tract, evospinal tract, vestibular spinal tract, tactospinal tract, vibrospinal tract, corticobulbar tract, and corticorubral tract. These tracts are from their physiology. You've already studied about them in the physiology. Actually, I was revising so that we must be able to clearly understand what upper motor neuron is. Upper motor neuron layers, the layers of the neural pathway above the anterior horn cells of the spinal cord and the motor nuclei of the cranial nerves. They are also called pyramidal insufficiency. Let me tell you again, the layers that are in the cranial nucleus and from here to here. So the blue color is going and red color is going to indicate you about the upper motor neurons that are at the level of the brain as resulting in cerebral infarction. That is at the level of the spinal cord, corticospinal tract linears. While the lower motor neurons are after the nerve exits from the spinal canal to the peripheral muscle when it is going towards it. So the this part after exiting from the spinal cord towards the muscle and the muscle itself, they are all under the lower motor neuron. Fine. So what are the signs and symptoms of upper motor neuron aliens? Possibly they are going to give you loss of voluntary skillful movements. Babinski sign is positive. Loss of superficial reflexes. Weakness with no muscle atrophy. Spasticity. Hyperreflexia. Pseudobubble palsy. Basically, the spasticity, pseudobulbar palsy, they are the hallmark of upper motor neuron. Let me tell you what is the spasticity, what is this pseudobulbar palsy, and what is this Babinski sign. Spasticity is a state of sustained increase in the muscle tension in response to a muscle lengthening, particularly when you're performing the passive movement. What it is sustained, a state of sustained increase in the muscle tension when you are going to lengthen that muscle, particularly with the passive movement. The spasticity is said to be a state of sustained increase in the muscle tension in response to massive muscle lengthening, particularly when you're doing passive movements. What it is, I'm again going to tell you about the pseudobulbar palsy right now, then we'll move towards the spasticity. Pseudobulbar palsy is pseudobulbar palsy. Actually, it results from upper motor neuron lions to the cortical bulbar pathways in the pyramidal tract. Basically, bilateral lion of the upper motor neuron, especially to the muscles of the tongue, face, speech, and swelling, is going to give you this palsy. Coming towards Babinski sign, what it is. This is normally when you're going to give a noxious stimuli around the plantar aspect of the foot. And what it is going to do, if the fingers of the toes are going to get into flexion, like in this picture, they are going to go in flexion. If this goes in flexion, it means the Babinski sign is negative. That's a good thing. But if you tap your plantar aspect of the foot with a noxious stimuli, and what's going to there would be there if there is a fanning of the finger and the thumb is going into extension, this is positive Babinski sign, and this is actually a pathological state. Positive Babinski sign is a pathological state that is going to tell you as upper motor neuron. While the other is going to tell you about the normal like Babinski sign that is actually said to be negative. Coming towards electrical stimulation, what's the effect of the electrical stimulation? So whenever there is a lion of upper motor neurons, there are changes obviously in the lower motor neurons and on the muscles, which may lead to altered electrical reaction. So upper motor neuron layers are also going to affect muscles and lower motor neuron layers because they obviously convey the message to them. Consequently, a normal type if response is obtained with the electrical stimulation, although sometimes the nerve and muscles are hyperexcitable and they react to even lower intensity of the current that normally required. Moving towards the lower motor neurons, what are they? What you know by the word lower motor neurons? All the voluntarily movements depend upon the excitation of the upper motor neurons and lower motor by upper motor neurons. Only the neurons that innervate the skeletal muscle fibers. Basically, these lower motor neurons are the final link between the CNS and the skeletal muscles. The link between the CNS and skeletal muscles is your lower motor neurons. Coming towards the classification of the lower motor neurons, we know lower motor neurons are classified on the type of the muscle fibers, alpha motor fibers and gamma motor fibers. Alpha motor neurons are basically that innervate the extrafusal muscle fibers. The most numerous type of the muscle fibers they are, and the one involved in the muscle contraction. While the gamma motor neurons innervate the intrafusal muscle fibers, together with the sensory efferents compose the muscle spindle, and they act as a part of the system for sensing the body position as well. Coming towards the topic of the discussion, that is lower motor neuron lineage. And basically, they are going to affect the nerve fibers that are going to convey the message of the CNS to the muscle. So, traveling from the anterior horns of the spinal cord or the cranial motor nuclei towards the relative muscles. So, these layers are going to affect that nerves. Let me tell you a few signs and symptoms that are going to be occurring due to this lower motor neuron layers. They are like flaccid paralysis, muscle atrophy, hyperreflexia, muscle hypertonicity, and fasciculation. Let me tell you or revise again what is flaccid paralysis and what is fasciculation. So flaccid paralysis is weakness, paralysis, and decrease in the muscle tone. while the fasciculation is a brief, spontaneous contraction that is going to affect a small number of the muscle fibers and often causing a flicker of movement. This is said to be fasciculation, while flaccid paralysis or flaccidity is weakness or paralysis or decreased muscle tone is known as flaccid paralysis. Let me tell you about the classification of the nerve injuries. I mean, how we have classified these nerve injuries. Basically, there are two types of classification. One is Sandin's classification. The other one is Sunderland's classification. According to Sandin's classification, it has been classified into three types. Number one is your neuropraxia. We are very familiar with this term. The second one is axonotmesis, and the third one is neurotomesis. According to Sunderland's classification, it has divided into five types. Number one, first degree, second degree, third degree, fourth degree, and fifth degree. What we are going to study in detail is our Sandin's classification, in which we have classified into three categories. That is, one is neuropraxia, the second one is axonotmesis, and third one is neurotomesis. Let me tell you about neuropraxia in detail. What it is and why it is, what's going to happen, how you're going to get the effects after neuropraxia. Basically, neuropraxia is due to actually a mild nerve injury. As we will categorize these nerve injuries according to the severity level, and this one is the neuropraxia is your mild injury with the motor and sensory loss with no evidence of Valerian degeneration. Valerian degeneration is basically a process that results when a nerve fiber is cut or crushed. So in neuropraxia, there is no Valerian degeneration. And nerve dystony conducts normally. Nerve is normal that is going to conduct impulses like dystony. And recovery may occur within an hour, the days, the weeks, and up to even few months. While in this neuropraxia, actually what happened is there is somehow some compression over the nerve that is going to like either cause a partial blockage or complete conduction block. And what we have to do is we have to actually remove this compression. We have to deal with this compression that is going to suppress the nerve. This can either be due to some injury or due to some inflammation or due to some sort of inflammatory activity that is going to compress the nerve. So what's going to happen, we said bruising or pressure is going to make the nerve incapable of conducting the impulses past the site of laying. But this damage is not severe enough to cause the degeneration of fibers. We earlier said neuropraxia does not involve the degeneration of the fibers. It does not involve the Valerian degeneration. Focal demyelination or ischemia are thought to be the etiology of the conduction block. They can be either due to a reason of the complete conduction block, or either they may be the reason of the partial conduction block. If the electrical reactions are tested on the affected muscle, a normal type of response is going to go. We're saying there is somehow layer in a nerve. Let's suppose in case of carpal tunnel syndrome, there is a layer at the level of the carpal tunnel over the median nerve. So what's actually the issue is there is inflammation around this tunnel due to which the median nerve is going to compress, due to which there is tingling and numbness in the hand and resulting to weakness, and so on. So if in such a case, if the electrical reactions are tested over the affected muscles, a normal response is going to occur. Median nerve is going to respond normally if we're going to test it distally. But there is a loss of response to stimulus applied above this level. If we're going to give a stimulus above this level, there would be no response here in the hand, because this median nerve is going to have somehow conduction blockage, due to which their impulses are not able to get transferred from this area, and due to which the messages from that we are actually giving here is not able to reach here. So this gives an idea that when I stimulate at this level, the message is not going to convey to the hand, to the finger, but when I directly give the message to that certain muscles, they are going to convey the message. It means on this way, there is some line, and we can actually assess by checking at this. After crossing this level, we may see and we may find that the message is going to be conveyed. It means there is some issue at this level that is going to give you an idea about the site of the lesion. And it also gives you the idea about the extent of the lesion, either the response is present or deep or markedly low. So it gives you an idea. Now moving towards axonotimosis, that is the second degree of the nerve injury. It is commonly seen in crush injuries. In this site of injury, axons and the myelin sheaths are broken, yet the surrounding stroma remains partially or completely intact. Valerian degeneration occurs in this, but subsequent axonal regrowth may proceed along their intact underneural tube. Or said, Valerian degeneration is the disruption of the myelin sheath and axons along the entire length of the nerve below the site of the layer. And usually it takes 21 days to show you complete Valerian degeneration. So after 21 days, if you are going to perform electromyography, it is going to tell you that Valerian degeneration has occurred. But before 21 days, if you are going to do electromyography, it's not going to tell you the exact picture of Valerian degeneration or the exact picture of the axonotimosis. So you have to wait for 21 days at least in order to get what is actually the extent of the nerve lesion. We can see it after the 21 days. So we said why the neurotomesis, this is the third degree, a nerve has been either completely spared, it hasn't completely injured, so markedly disorganized with scar tissue, axonal regrowth is not possible, impossible, and due to which, if we get to know this is neurotomesis, who would obviously say as a nerve has been injured, a nerve has been severely cut off, prognosis for the spontaneous recovery is extremely poor without surgical intervention. So what we can do in case of neurotomesis, there is poor prognosis by using physiotherapeutic modalities. If we want to get with a good prognosis, we can have an option of going towards a surgical intervention instead of electrotherapeutic modalities. This is a picture to show you 3 degrees of the nerve injury. The first one is going to tell you about the neuropraxia. Second one is going to tell you about axonotimosis, and third one is going to tell you about neurotomesis. And this is a picture to show you how the surgical interventions are going to do. They are going to cause the suturing of this underneural tube. Either you can suture this myelin sheath and get gradual regeneration. This is another picture to show you about when the nerve has been cut off, it may result towards Valerian degeneration. The nerves usually have an option to go towards the nerve sprouting that is going to connect to the nearby nerve. It may get connected to the surrounding nerves and get the neural spread. Now, this was all about the neuromotor neuroimaging, about neuropraxia, about axonotimosis, by neurotomesis. Now, let me tell you about the defects of the neuromuscular junction. And the commonest defect of the neuromuscular junction is basically in seeing myasthenia gravis. As we know, when we studied in the subject of pharmacology about the myasthenia gravis, that it is a solely progressive, autoimmune disease that is going to cause progressive muscle weakness, and this weakness is basically due to the increased level of antibodies, and they are basically going to affect their receptors, and due to which the acetylcholine is not able to attach here, and due to which acetylcholine is not going to do the proper action. It is not going to able to cause the muscular contraction and further on the next action. Right now, the issue is at the neuromuscular junction level, but using with the electrical currents, we are not able to directly achieve or directly have an effect on these neuromuscular junctions. So the issues that are going to actually neuromuscular issues are also give you the loss of voluntary power. The patients with myasthenia gravis, they are showing to weakness. So it might come in our mind being a physiotherapist that oh, it's muscle weakness, so we may do something by doing some stimulation and this and this. But right now, in this case, we must know about the pathology. Why it is so? It is actually due to the neuromuscular junction level, due to the deficiency of the activity of the acetylcholine alpha receptors. Fine. So we can't like activate degrade these and or antibodies with the help of crayons, or we can't increase the level of the acetylcholine with the help of this crayon. So our crayons are not actually applicable and not going to give you any good like result. So what we can do is we can not like directly deal with every condition that is going to give you loss of or reduction of the muscle part with the use of electrical currents. Moving towards the last point, that is related to the functional disorder. There are certain functional disorders that are going to give you loss of voluntary power, but this may be either due to some psychological issues like some hysterical paralysis, in which there is no alteration in the electrical response. When you do electrical currents and do apply it, everything is normal, but the person is not able to voluntarily show the, like you can say, contractions. So while technically everything is okay, so what it is, it comes to goes to another like differential diagnosis that is going to come deal with the psychological issue. So hysterical paralysis, an uncommon type of the conversion disorder, as difficult to diagnose in case in which the symptoms are difficult to explain, neuroanatomical and functionally inconsistent, hysteria should enter into a differential diagnosis. When everything is okay and you're going to get every like neuroanatomical and functionally everything is okay, and still the muscle is going to show you less power and there is a loss of voluntary contraction or reduction of the voluntary contraction, then you have another like differential diagnosis. Should we move towards hysterical paralysis, some psychiatric issues? So conversion disorder causes the patient to suffer neurological symptoms. The patient usually say that he has numbness, she has numbness, blindness, paralysis, fits, without any definite definable cause. When you do assessment, everything is okay. There is no specific cause due to this numbness and paralysis and fit. I thought that these symptoms basically arise in response to some stressful condition or some stressful information or situations that is going to affect the patient's mental like health. So conversion disorders is considered as a psychiatric disorder. Now move towards the closing point of this lecture. As we have gone through the basically we have gone through the electrodiagnosis in which we have studied about the lower motor neurons in detail, about the neuroprasia, about the exonemosis, about the neurotomesis. So this was the main like topic of the discussion of today's lecture. With this, I'm winding up the session. Inshallah, I'll see you in the next lecture in which we are going to study about electromyography. I'll see you in the next lecture. Till then, Allah Hafiz. Stay home, stay safe.